Hi, everyone. It is the top of the hour, so we're going to go ahead and get started. Welcome to the Pediatric Share Safety webinar series. Today, we're going to cover preventing CLABSIs in pediatrics. I'm going to run you through some logistics real fast. If you would like to get on the telephone, we are going to have some open discussion. You can go over to your audio box, open that up, and click on the telephone option. It'll give you a dial-in phone number and an access code, and then you'll press pound. You'll be prompted to enter in an audio PIN, and then you can keep yourself muted on your end. We will also have muted on our end, and it'll tell you when you're unmuted so you can speak to any of your questions or concerns. If you're having trouble with this or you have any other logistical questions or concerns, please put your questions and comments in the question box. We can help you with that behind the scenes. And with that, I'm going to hand it back to Missy.
So welcome, everybody. My name is Missy Shepard. I am the Executive Director for the Solutions for Patient Safety Network. And today we have a great lineup of speakers. We have our CLABSI leadership group here with us today. We have Michelle Faisana, Mike Gutzeit, and Margie McCaskey, as well as Holly O'Brien. We also, today for our webinar on CLABSIs, we have a partnership with the Joint Commission Resources, and together with Solutions for Patient Safety, we're putting on this webinar series. We're having a little bit of a technical difficulty with the screen. Hopefully you guys are able to see the slide deck, but I'll go ahead and let you know who my partner is from the Joint Commission Resources. Her name is Deb Nadzum, and she worked with me on the HEN work for the Partnership for Patients program. So we've worked together for quite a while now. And she's with us today, but she's actually at the airport, so she may not be able to speak. But we'll make sure we check in with her here in a little bit. So we're still having some issues with the slides. So our CLABSI leaders, as I mentioned earlier, are with us today. So you can see their photos here. We have Margie, Michelle, Mike, and Holly. Our objectives for today are to learn about the Solutions for Patient Safety Pediatric Safety Learning Network and understand the CLABSIs for central line associated bloodstream infections. Learn from the SPS member hospitals' experience in building evidence for the SPS prevention standards. And we'll also share with you the best practices and top interventions for preventing CLABSIs that we found in the SPS network. We're also going to cover application of high reliability theory to achieve desired outcomes. And with that, I'm going to turn it over to Margie for our patient safety story.
Well, hi, good afternoon, and thank you for joining us. I wanted to just tell you a story about a CLABSI that really brings home the fact that children are still children. Even if they have a central line and they develop a central line infection, they still act like children. So this is a 12-month-old little boy who's been in and out of our hospital many, many times and has short bowel syndromes, had many bowel resections, always has a central line of some sort, and he had a double lumen PIC placed, which they thought at the time would be a great access for him. He could get his antibiotics, he could continue to get his TPN. Everything would be wonderful, except if you think about the traditional location for a PIC line in his forearm, it puts the caps at an ideal spot for him to suck on them and chew on them and be a normal baby wanting to put everything in his mouth. So that's what happened, and despite the fact that the nurses tried everything they could think of to keep it covered up, put a long sleeve sweatshirt on him to cover up the lines, tape the lines up on his arm higher so they weren't down by his wrist, he still developed the line infection. And so this slide is an example of the way we send out our huddle information. Holly's going to talk about the importance of those post-event huddles in just a little bit, but this is the information that we send out, that what happened, what could we have done differently, what are some things that we just didn't think about. This is a teething patient who likes to chew on things, and what are some key points to remember for all of the staff when they have patients of this age, to think about the risk of line placement and where it's going and how accessible it's going to be. to that child. So just one example of how kids are just a little bit different than adults.
Thanks, Margie, for sharing that with us. If you have any questions about the patient safety story, don't forget to put any questions that you have in the chat box. Again, this is Missy, and I just want to remind everybody of the Solutions for Patient Safety mission, which is working together to eliminate serious harm across all children's hospitals. And our current goals for 2015 and 2016 are a 40% reduction in hospital-acquired conditions, also known as HACs, and a 10% reduction in readmissions, as well as a 25% reduction in serious safety events. We are a network of 88 children's hospitals, and you can see the logos of many of our partners and members within our network. And currently we represent a little bit over 50% of admissions for pediatrics. But by way of these webinars, we're hoping to reach all the other hospitals that are in our network and share our best practices. With that, I'm going to turn it over to Dr. Gutzeit to give us some information about CLABSI in pediatrics specifically.
Great, thanks, Missy, and I'd like to reiterate what Margie and Missy have said. We so appreciate your time today. There's so many things that compete for your time. We're hoping to provide some high value to you with the information that's presented today. So I'm going to talk a little bit about preventing CLABSIs and some of the unique challenges. And let's start with a question to consider. In this age of value-based care and consumerism, we always think about cost. So what is the attributable cost of a pediatric CLABSI? And you can see the responses there. So in your mind, just kind of think about that and what the actual cost would be. And we wanted to include the cost that we have data on related to some of the hospital-acquired conditions. As you can see, a CLABSI incurs about a $35,000 cost. And I wanted to put that in perspective. You're going to see some data from the Solution for Patient Safety Network a little bit later on that showed that, for example, in March of this year, we had 164 events of CLABSI. And if you total that up to the kind of back of the envelope calculation, you'd see that that amounted to about $5.7 million in additional healthcare costs. So that's just 88 hospitals over a one-month period. Imagine multiplying that by the over 4,000 hospitals across the country. So this is work that really we need to invest in because the investment helps to improve the whole value that we're looking at. So move on. So although CLABSIs are not unique to children, some of the conditions are, and certainly Margie shared some of those points with you when she talked about the case example that was presented early on. The needs for children are definitely different than adults. They do require attention in areas, especially around anatomy and behavior, and these pose challenges. You all know that in a children's organization, there's age diversity, so you might be treating the smallest of the small and the largest of the large kids, anywhere from micro preemies to adult-sized individuals. We know that the immune function is often a challenge with children, not only because of their age and the immaturity of the immune function, but often because of the conditions that bring them into the hospital in the first place related to underlying medical care that they need. We also talk about the potential toxicity of the agents that we usually use to reduce the likelihood of having infections. Another variable that we've really started to learn more about is that home care standards may differ from company to company and across various industry or various places across states and things like that. One of the concerns that we have here is that, as you can imagine, most children spend more of their time with their central line outside of the hospital than they do inside of the hospital. So spending time working with some of those home care delivery agencies is important. We know that in kids, maintenance is much more important than insertion in terms of prevention of central line associated infections. And again, as Margie said, kids are kids. They're constantly in motion. Hygiene is an issue. Those lines look so attractive as something to put in the mouth. We're always thinking about how we can strategically place them so that they're not in harm's way from that standpoint. So in terms of looking at conditions that generate unique pediatric safety risks, the obvious answer would be if we didn't put any lines in, there would be no infections. But unfortunately, that's not the case. And so the reality is, how do we deal with that? One condition that we talk about are the size of the catheters. So in the micropreemie population, we might be placing literally angel pasta hair-sized pieces of tubing into the vasculature, and these are obviously prone to complications, difficulty with keeping the dressings clean, and also the close proximity to other anatomy sites, as we referenced earlier, trachs, G-tubes, things like that. We do know that there is a high potential for extravasation and effusion due to thinner vasculature. Again, using the neonatal example, we know that the vasculature of neonates is very immature, sometimes no more than a couple of cells thick, and there can be effusions that occur if the extravasation or extravasations and effusions that can occur from movement of that line. We also know that peripheral IV access is a greater challenge in children, and there is a potential for line migration, as I had mentioned earlier. So those are some of the unique challenges that we face in pediatrics. We're all aware of those, and we try to think about how we can mitigate those as best as possible, knowing that we can't eliminate, but we can certainly mitigate. I think at this point I'll hand off to Holly O'Brien, who's going to share the operational definition and some information around that.
Hi everyone, thanks for the opportunity to speak with all of you today. I'm going to very quickly just go over the operational definition that we use for SPS to just make sure we're all on the same page here. Next slide. So what we had talked about with the CLABSI leaders for SPS is we wanted to be consistent with the national definitions that already existed for CLABSI. So we stick with the standard of the National Healthcare Safety Network, NHSN. We use the same definition that they do. So we start with the question of how often is a patient harmed due to central line associated bloodstream infections. Next slide. And then we look closely at all of the areas throughout our hospitals, all of our inpatients and observation kids, and we collect data on all of the units, but we also look closely at 4 specific units. We look at our PICUs, we look at our critical care ICU, we look at our NICU, and then we look at hematology and oncology. We include all of our patients, again, that are inpatient and under observational status. We usually exclude kids that have been here for less than 48 hours, yet we still look at all of those cases because we really follow the NHSN criteria. And many of you out there might know that that document is many, many, many pages long. So that's why I'm not going to go into great depth on that today, but we follow the NHSN guidelines for our definition. Next page, or next slide. The other thing we think about a lot with our numerators is the kids that have, if you have multiple infection sites from the same organism, that does count as one infection. Another key piece to make sure we're clear about for the denominator is the total number of central line days. It doesn't matter how many lines a kid might have. A line day is a line day regardless of how many insertion sites they may have. So we look at our number of bloodstream infections per 1,000 central line days. That's our numerator and denominator over 1,000, and that's how we determine our CLABSI rate. Next slide. I think it's 2 more slides. You can keep going. So when you look at our SPS data that we've been collecting over the past 3+ years now, we've had a really nice overall decrease in CLABSIs. We have an 11% overall reduction in CLABSIs in the last few years. We are acknowledging there is a spike. We had 2 spikes. We had a spike last year at this time, and then we've had a spike the last 2 to 3 months now, and we're really looking closely at those to determine what factors could be contributing to that. But overall, we've had a nice decrease in the past 3 years of infections. So I think I'm going to turn it over to Michelle now to take over.
Thanks, Holly. Hi, this is Michelle Faison. I'm the Medical Director of Quality and Safety at Riley Hospital for Children. We'll go on to the next slide. I'm going to talk with you a little bit about bundle reliability and high reliability theory. I'm not going to go into great detail on this slide, but just to point out that I think it's been very helpful and necessary for hospitals to put together key driver diagrams for the various hospital-acquired conditions. And so we did this as well for the different hacks as well. So this is our CLABSI key driver diagram, which will be included in the slides. And so I think it's a nice way to be able to set up what are your interventions based on your key drivers. And this one is mainly based on what is it, how do we need, or how do we get to be reliability for our maintenance and insertion bundles, as well as data and high reliability methods. So we'll go to the next slide. So what we know about prevention bundles is that if we are reliable to the process, the outcomes overall will improve. And even though it says the outcomes will decrease, that's meaning that CLABSIs will decrease. And so over the last actually a few years since we've all been a part of SPS, we've really spent a lot of time talking about what should be standardized. And I think in terms of CLABSI, we had obviously a lot of, we were sort of in a better place than maybe some of the other hospital-acquired conditions were, because there had already been a lot of work and a lot of history in terms of the prevention bundle. So we'll go to the next slide, which shows, and this, I think this just points out things about having two people at the bedside that can be helpful for observations, can also be helpful to ensure that both people or the person who's doing a dressing change or a cap change is doing, is performing all the right steps. And I think culture plays a large role in that, being able to step up and say, hey, I think you might have missed that or whatnot. We'll go to the next slide too to talk a little bit more about how we actually went through and decided to identify the prevention bundle. So all of our different aviator hacks followed this same process. We met the co-leaders and the subject matter experts, talked about what needed to be in the prevention bundle, and the clinical steering team actually ultimately had the decision making authority to decide what was adopted. So it wouldn't be, we would not have been true to ourselves if we didn't do a literature review, figure out what was actually out there, and that's exactly how this started. And then had people in 2012 and 2013 decide what the bundles were in their own institutions, and then using a survey said, okay, what are people actually doing for the bundle process? And then we, as the hack leaders and the subject matter experts, reviewed all this analysis, and it was an in-depth data analysis. I think the four of us could tell you we remember quite well going through all of the funnel charts and various things that we did to decide where we needed to be to develop these prevention standards, and then recommendations as well. And that was all presented to our clinical steering team and then adopted in May of 2014. We'll go to the next slide. So we talk about, in the SPS prevention bundles, we talk about standard elements and recommended elements, and that the standard elements are that there's strong evidence suggests that implementation would be associated with decreased harm. And so that's what we say, that every hospital, every SPS hospital should implement and measure the reliability of this element. And I think the key piece to this is measuring the reliability, because you don't know how reliable you are to it unless you actually sit down and evaluate and go back and look. And then recommended elements were elements where we thought there was some data that showed, or clinical expert opinion that showed that this could be effective, but it wasn't, we weren't as sure maybe on some of those elements, because maybe that it hadn't been out long enough. Next slide. This is the insertion bundle. I'm not going to go through this step by step. These will not be of any surprise to, I think, anybody on the call. And then the next slide is the maintenance bundle. What you do notice on this one, you may notice that there are standard elements, which are the usual standard elements, which won't be of any surprise. Oops, and then, this should be, it is the maintenance bundle. Sorry, the slide says insertion, but it actually is a maintenance bundle. And then the last, you'll notice at the bottom, there are two recommended elements. And those recommended elements are that we do an in-depth review of all identified CLABSIs and multidisciplinary involvement. And what Margie showed you at the beginning when she talked about the patient who had the CLABSI, that's one of the ways we do that here at Riley. And then we also said that daily CHG bathing and linen changes are in the recommended elements. We'll move on to the next slide. So this is where we talk about the measurement, and this is key to understanding what's going on, I think, in institutions, is really looking at, okay, what's your reliability to your bundle? And I think what's been exciting for us to see is that we've clearly seen when hospitals have increased reliability of over 90%, that we can see that that correlates with decreased CLABSIs. And so similar to that initial slide that I showed you of increasing your reliability to the bundle decreases your outcomes. And so this one is insertion. I think most hospitals, we can go on to the next to maintenance. I think most hospitals have really worked a lot on insertion, and so we would tell you that that's probably, or that not even probably, that's definitely not where the challenges lie still for CLABSI. That might have been a different story years ago, but right now where the money is at and where the work is that still needs to be done is around the maintenance bundle. And so you can see here that when we started SPS, when we started out, because this actually goes back to 2000, I think that data says 2010 on there, or 11, sorry, 2011 and 2012. You know, the maintenance bundle reliability was much lower at 60%, and as we have done a lot of work and actually done some focused work on different elements of the bundle, we have been able to incrementally see the reliability to the bundle improve. This has been significant work that hospitals have done, and it takes vigilance and observation and drilling into your data to really understand, and that's why I think that key driver diagram is so important. You'll notice that there's some annotations on the right hand of the slide, and those sort of annotate points when we did different interventions. So January of 2013 to September of 2013, we had a focus on increasing reliability. We in June of 14 released the SPS prevention bundle standard elements, which we showed you previously, and then in September of 2014 we actually put forth a 1 at 90 challenge where hospitals were given the opportunity to choose a hack to be able to get to 90% reliability to the bundle, and many of the hospitals in SPS chose CLABSI, and we did a lot of work with those hospitals to help them get to 90% or greater. I'll move on to the next slide. I will turn it back over to Margie and Holly. They're going to give you some exciting news about top intervention.
Great, thank you. I would say one of the best things about being in SPS is that the all teach, all learn philosophy is so incredibly important and gives us a wealth of information. So what Holly and I are going to share with you are some of the top interventions that we've tried, that we are successful with. We're going to highlight just a few of those to talk about some specifics. We could make it so easy if people would do just two very important best practices. One would be to always ask, do we still need this central line? It is a clear and well researched and well supported fact that if you don't have a central line, you can't have a central line infection. And if you're not using the line, then get it out of the patient. So we really support that best practice. And then the second one looks so simple, and it's the one we struggle with. It's getting your insertion and maintenance bundle compliant up over 90%, being sure that every time you take care of a central line, you are taking care of it the right way, the same way, with every single entry, every single dressing change, and really emphasizing hand hygiene and scrubbing the hub and making sure that it's absolutely right every time you do it. Can we go to the next slide, please? Thank you. So here are some of the top interventions that we came up with when we were brainstorming. What do we think really works? And my personal favorite is get everyone at the table. I think you will see a tremendous difference in your outcomes when you get past well, doctors insert the line, so that's their business, and nurses take care of the line, so maintenance is their business. It really is a combined effort, and everyone has to be involved and has to be on the same page, in the same conversation. Within the SPS groups, we all have hack champions. Each one of our hospitals has a CLABSI champion who really spearheads the work. They don't do all of the work, but they're the cheerleader, the content expert, the 200% supporter of the CLABSI work so that it can move forward in the institution. We can't get anywhere without educating and engaging our families. Many of our children have central lines for a long time, and they go home with them, and the parents are well versed in how to take care of them. And if we don't include them in our work, we're missing out on a huge opportunity. we ask for standardization across the entire hospital. We still have SPS hospitals who have not spread the bundle across every unit. We have many that have, and they're seeing great results. This is not a problem that is just limited to the PICU and the NICU or the HEMONC floor. It does impact everyone, and our units that have very few central line days will say a central line scares the daylights out of them. They're going to be very careful with it. They probably have better compliance than the units who see them all the time, all day long. Dating and timing dressing changes, it's a challenge. You wouldn't think that would be so hard, but it's a challenge. How are you going to document that? How are you going to make sure that you know when the last time this tubing was changed or this cap was changed, and when does it due to be changed again? Looking at every opportunity for, does the dressing need to be changed? Is there something we can do differently? Is someone else putting together a cap change kit that makes great sense that we need to try? Holly's going to talk in a little bit about those post-event huddles and really looking at where were the opportunities for improvement. Where can we do something different? Maybe unique for this patient, maybe unique for this patient population in general, or maybe not so unique, but something we just need to change and do differently. Reinforcing what went well. That's, you know, being committed to staying resilient. When it goes well, we celebrate like crazy. When it doesn't go so well, we try to, you know, keep spirits up and bounce back. Auditing is such an interesting topic. We're going to talk about that in just a second. Everybody says, oh, we have to audit. But unless you are out looking to see what is going on with your line care, you really don't know what your compliance is. And you may think that your compliance is fairly high until you actually go and observe. And it might be disheartening the first time, but then you know you have opportunities for improvement. And then finally, those audits don't do any good at all unless you're sharing them with that frontline staff, with the people who are doing the work, to say, hey, I know you think we're doing an awesome job, but look at what our compliance is, and here's how we can make a difference. If we would just get this up to above 90%, we'll see a decrease in our infections. So I think the next slide talks about auditing a little bit more. Those of us in SPS were in Chicago not too long ago, and Helen DeVos Hospital in Grand Rapids, Michigan shared their process auditing methodology. And some of you may be familiar with this. It's related to kamishibai, which is a Japanese term that means paper drama. When the word was invented in the 1920s, it was related to traveling storytellers who would use cards with pictures on them and would move the cards on the stage and tell a story. So kamishibai cards are a way of telling a story about your auditing process. And this is an example of on both sides of the kamishibai cards that Helen DeVos uses. Basically what this is just a visual control. The auditor pulls the card, goes to the staff. The very first thing on the card says, identify a nurse caring for a patient with a central line. Obviously, that's what you're auditing. So then there's a series of questions. These cards are meant to be very self-explanatory. So you don't have to know all the ins and outs of the central line care bundle to be able to audit to the bundle. You follow the card, ask all of the questions, look for all of the things on the card, and this is always measured in an all or none point system. You either get it all, or if you have a miss, then the card is red. The cards go back on a board so you can, in an instant, see that today when we audited maintenance bundle compliance, we were in the green. We had everything right. Or it was red and what was missing. And you can tell from the documentation what was missing, and then talk about that in their unit-specific safety huddles. So it really engages all of the stakeholders. It brings the physician staff. You can get a multitude of people to do these audits. It does not just have to be staff from your unit. Many hospitals have their leadership team or their executive team, medical director of quality, going out, grabbing a card, going to a bedside, and asking questions about this central line. I think it puts everybody on the same page with line care, and it also brings to the forefront, what are we doing? And look, it's very obvious, it's very visual how we're improving on our bundle compliance. So I think with that, I'll give this to Holly. that right?
Thanks, Margie. So really thinking about some of those best practices that Margie was just speaking about, those are what we want all of our staff spending our time focusing on. We want to be spending our time working on preventing the CLABSIs from occurring in the first place. I also wanted to speak a little bit about a best practice related to huddling when you actually do have a CLABSI identified, or you suspect you may have a CLABSI. And so what I would recommend for this is really getting a tight process, a quick process, as close to real time as possible, to really huddling and looking at these CLABSIs a little bit closer, because from past experience, from the past many years, that's what we ended up spending most of our time on, was trying to go back in time, a week later, 2 weeks later, and trying to really go through investigations that way, and it's really hard to do. So what we've been working really hard to do is having a huddle within 24 hours of identification of a possible CLABSI. And I really truly mean possible, because at that point you have your second positive blood culture, and you really are huddling to determine, is this a CLABSI, is it not, or do I need more information to move forward? And we've really tried to work hard at actually having that within a half business working day of actually having that huddle scheduled. The other thing is really making sure all those key customers are aware, making sure the medical leadership of that area, the nursing leadership, the frontline staff that took care of the patient for the last 72 hours, your infection prevention department, your safety department, risk maybe need to be involved, making sure all those key customers are also invited to that huddle. And what's even more important is the feedback loop. So if people can't be at that huddle, what was determined at the huddle? Was it determined that, yes, this is a CLABSI? No, it's not. We need more information. And really closing that feedback loop so all those key customers are very clearly aware of what the plan is moving forward, and if there were deviations determined, that they're really clear about what those deviations are too. And then really getting out there and being transparent about that data, not just sharing it with the CLABSI team or your CLABSI members, but sharing it with others, sharing it all the way up through your C-suite, and making sure everyone is aware of that CLABSI occurred, and if there was some deviation that was identified, what that deviation was and what we can do to improve in the future. So this would definitely be a best practice out there, is really working on those rapid cycle huddles when you have identified a possible CLABSI. So another thing that we've really worked closely with is engaging our families. I know Margie also spoke to that briefly earlier, but really making sure our families clearly understand the importance of the bundle elements and how to comprehend how they can help keep their child safe too. We have a lot of conversations with CLABSI, some of the other hospital-acquired conditions as well, but definitely CLABSI, in really working closely with those families to understand that, yes, we need to keep those central lines, if they do need the central line in, don't be disconnecting and reconnecting so that the kids can walk around and be disconnected. So I know it's can be mixed in with the patient satisfaction, and you really want to balance that out. So really what it needs is a really clear conversation with families and making sure they really do understand the best practices for central line care. It's really about engaging them, and even to the point of giving them a card that they can be using to really help say what it is they can do on a daily basis to be monitoring and engaging with those families. Even here at our hospital, we've been experimenting with having the families do the auditing while we're doing the dressing changes, and letting them help time us and getting involved with that really helps them feel much more engaged with that practice. So definitely engaging families is another best practice for CLABSIs. So this is a really great message from the parents. There was 2 parents that were at our national learning session a few weeks ago from Helen DeVos, and the parents, and their comment was, oops, we just lost it, was their big aha was, keeping children safe isn't expensive, it's priceless. And I really think that's kind of our new tagline of SPS. We'll probably be really talking a lot about that for the rest of the year, because it's just such a great statement that they've thought of and they put together for us. So that came directly from our parents. And now I'll turn it over. I don't know if Deborah's going to take over or if Missy's going to take over.
Hi, this is Missy. Thanks so much, Holly and Margie and Michelle and Mike, for all that information on pediatric CLABSI and kind of sharing or doing a form of all teach all learn from the SPS network, which we did get a question in the chat box asking what SPS means. SPS is just an acronym for Solutions for Patient Safety. And if there's any other acronyms that you've seen in the presentation that you're not sure what they stand for, please put a note in the chat box and we'll go ahead and answer that question for you.
We do have another question asking where they can find this presentation after the.
So this presentation will be posted to our public website, and I'll go through at the end of the webinar today how to get to this information on our website. So Deb is at an airport today. I'm not sure if she can talk or not, but I will go ahead and go through the polling and then we'll check in with her in just a second. So we had a couple questions for you today because we want to learn a little bit about your practices to prevent CLABSI. And our first question, we're going to launch the polling that you'll see on the screen, is we want to know if you're measuring bundle compliance within your hospital. And I see a lot of SPS hospitals on the line here today, so hopefully the answer will be yes. We'll give it just a second. I'm seeing some really good results here. Great. So it looks like many of you are measuring bundle compliance. So our next question is what unit? So you guys are starting to respond there. Okay, and we'll go ahead and share the results for that as well. A lot of PICUs. That's great. We also want to see if you're sharing your CLABSI data with your frontline staff. Okay, we'll go ahead and share that as well. 100%. I don't see that very often on polling questions, so that's great. And we have one last question. If you're sharing your data with the frontline, what type of data are you sharing? We want to learn from all of you as well as what works well to motivate the frontline staff and keep them informed. So we had a couple questions here, or examples: rate, bundle compliance, raw data, days between or other. Seen a lot of days between and rate charts. We'll go ahead and share the results for that as well. Great. Thank you for sharing with us. That way we know kind of what everyone else is doing as far as sharing information. So with that, we are going to open it up for discussion. This is where you can put questions in the chat box relative to CLABSI, or if you have questions about the Solutions for Patient Safety Network. We'll give everybody a few seconds to get the questions put into the chat box. We have any?
Okay, so we do have some questions that's come in, and the first one is from Meg Bergson, and she's asking, in the lit review for CLABSI, has SPS evaluated use of alcohol-impregnated cats?
Hi, this is Margie.
So we'll turn that over to you.
Go ahead.
Go ahead, Margie.
I was just going to say there are a lot of topics that we talk about a lot. There is some literature and some mixed feelings about the CAPS. We didn't include it in our standards because one of the things we tried not to do was to put things in the bundle that would incur additional costs to hospitals. We wanted the standard elements to be, we want all of you to do these things, and to mandate go buy this product if you don't firmly believe in it yet. So there are a percentage of the hospitals that are using them. There are some that have tried them and no longer use them, and there are some that have said, no, we're going to perfect this first before we add something else.
Yeah, Margie, it's Holly. That's exactly what I was going to add to that conversation, is that we realized that a lot of hospitals were saying their bundle reliability wasn't high enough yet to move on to another piece, to incur an additional, cost and product and supply, that we needed to make sure that we were doing the maintenance bundle kind of in the bare bones. We were doing that right first. And honestly, a lot of the hospitals, once they start seeing that increase in their reliability, their outcomes were reducing. And so we just haven't gone that route yet, because we are seeing results when we can just get people to be consistent with the maintenance bundle as is right now.
Great. Thank you, Margie and Holly. Michelle or Mike, do you have anything else to add to that?
This is Mike, and I think Holly and Margie answered it very well. I guess the only other thing I would add is that as a group, we're constantly looking at what the next level of inclusion into the bundle elements are. Where's the evidence? What's the data? What's the most recent thing that's being tried out there? So it's a constant evolution and a constant shaping of what the next thing is that we might want to consider adding to the bundle. Michelle, did you have any additional thoughts about that?
It's Margie. Michelle's on service, so she had to go take care of an admission. So I would say, in total agreement with you, Mike, and I'm sure Michelle would say the same thing, that if we had to pick one that's what's coming next, it probably would be CHG bathing. That seems to be the one that, even though it's recommended, there are lots of hospitals that adopted that element.
Great. Thank you, Michelle and Margie and Holly. This is Missy again. I just wanted to introduce, we happen to have Dr. Steve Muthing on the line with us as well. He's the Clinical Director for Solutions for Patient Safety. Steve, can you hear us okay?
Yes, I can, Ms. Shepard.
Welcome. Is there anything you want to talk about with CLABSI, or to address the first question, or should we go on to the next set of questions?
Oh, just one brief comment. First one is to thank our fantastic HAC leadership. They've just done an amazing job of corralling all of us across 88 children's hospitals, and the clarity of their message, and then the use of data has just been so powerful to make it clear. And I loved your answers about that question, because we all think there might be some other missing items that are necessary to get us to zero. But the way you guys made it clear that that may be the truth, but we really need to get reliability and get everybody on the same page doing exactly the same thing. And it's that level of standardization when we get there that we'll really be able to answer these bonus questions, which is, okay, what else do we need to do besides do the basics reliably? So I just loved your answer, so thank you.
Great, thank you, Steve. We have quite a few questions in the chat box. I'm going to turn it over to Matt to go to our next question.
Okay, great. So we have a general question. It's just related to, how do you engage the frontline staff?
So Mike or Margie or Holly, do you want to respond to that one?
Sure. This is Mike. I'll start, and we'll try to answer these as succinctly as possible to get through as many questions as we can. So if people want additional information, certainly they can contact us, and I think Missy will share that information. I think engaging the frontline staff, there's no magic solution to that, and there's no secret sauce. I think it really is about transparency and clarity. I think we all started this journey with some information that we had, and when you go to the frontline staff and just ask them, just have a conversation with them about what they think, what their viewpoint is, what they would feel are the most important elements, you start to really learn quite a bit about it. And we have really found the power of sharing that information, sharing that data. As Steve had mentioned, when you start to show people that, hey, maybe if we just tried to get to 90%, we might see some really strikingly impressive results. It really motivates people because they feel ownership, and I think that's really the key, is how do we engage people so they feel that they're owners of this, and it's not just yet another thing that's being put onto their plate. that's one of the keys that I see. Margie or Holly, I don't know if you had any additional thoughts.
I would totally agree, and just think about it in terms of the goal for all of this is to attain high reliability. And when you think about having that sensitivity to operations in a high reliability state and really paying attention to what's at the front line. And once you start to do that, they get engaged because you're listening to them and you're listening to what works and what doesn't work. And you're telling me I'm supposed to do this, but how can I when the patient's always doing something else? And it's incredible to see it evolve over time, that they just get on board because they own it and they want to do better. Our nurses can tell you how many days it's been since their unit last had an infection, and they're very proud of that and want to keep it on the increase. Holly?
Thank you.
No, I don't have anything to add at this time. I just was going to wait for the next question and see if I could help address that one.
We have a lot of questions, and I actually wanted to let people know we probably aren't going to get to all the questions that are in the chat box, but we do have the email addresses of each of you that are putting questions in the chat box. What we will do is send those to our CLABSI leaders, and we'll get answers back out to you. But we do have a couple questions that we're going to be able to cover right now. So, Matt, what's our next question?
So this comes from Audrey Hubbard. Thank you for putting that in. And she's asking, our adult colleagues are no longer drawing blood cultures from the central lines. Are you aware of literature that supports this practice? Let me know if you need me to read that again.
So, Margie, I don't know if you have a closer handle on that question.
My first thought was, well, adults have bigger veins. They're easier to stick. We always get two sets now. We draw peripheral and if we're drawing from a central line. So it's a mindset, and no, I'm not aware of any literature that supports one way or the other, but it'd be nice if we could say, no, we're not ever going to draw them, but we know realistically that it just isn't going to happen.
So Mike or Steve, do you have anything to add to that?
This is Mike, and I would say no. I think that's about as accurate an answer as we can get. The fact is that there are differences in kids. We mentioned that earlier on in the presentation. So obviously something to continue to look at, but I don't think there's any strong desire to change that right now.
Great. So the questions just keep flowing in, and we'll keep going through them until we need to wrap up at the end of the hour. This one comes from Stephanie, and Stephanie, I apologize your last name if I butcher it. It's Oliviera. She's asking, are there any other PEDS areas utilizing midline catheters versus central catheters?
And Mike or Margie or Holly or Steve, are any of you aware of any?
Yeah, I'm wondering if she's referencing like a medline, like as in like a metaport. Is she talking about a port? Margie, do you think? Yeah, or maybe
midline, the shorter catheter.
Oh, a midline. I'm sorry, Matt. Then can you repeat the question?
I sure can. She's asking, are any other PEDS areas utilizing midline catheters versus central catheters?
Yeah, that's what she's asking.
Okay, oh yeah, go ahead, Margie.
I was just going to say we don't as a rule.
So we do sometimes in our NICU population, we have midlines, and sorry, I didn't understand the question at first. So we do sometimes in, it's case-by-case decision-making with the neonatologist, but we do have some midlines. Yeah.
Great, thank you. Next question, Matt.
So this comes from Pam Turner, and she's wondering how many of you are just on the phone. She's asking more, having problems with parents refusing the CHG bath.
So one of the things that I'll start answering that, and that's a good question. And I would like to thank everybody for these questions. These are very thoughtful questions, and I know we won't get to all of them. So we will commit to you that we will get answers out to those questions as they come up within the next few days. But in terms of parental refusal, one of the approaches, so CHG bathing was one area where we were struggling because in some populations the feeling was that we didn't want to disturb the patient, or it might be creating some challenges to other elements that were going on with the patient. And we've really changed the concept from CHG bathing to CHG treatment because it's part of a treatment plan. And that's actually helped to engage families quite a bit more because the feeling of, well, if this is part of the treatment plan, then it's really something that we want to include as part of the daily routine. And I think that's helped gain some traction. And also just, again, getting back to the simple communication of help us understand why it is that you may or may not want to use this treatment. What are the barriers that you're perceiving? Engaging in a simple conversation sometimes alleviates some confusion that may have been going on about what the plan was or what the approach was or what the desired outcome was.
I will add one quick story that was really helpful in increasing our compliance with the CHG treatments here. Was that we actually had a family come in, a mother come in with her CHG wipes when they were admitted, and she had been investigating online herself, and that really helped encourage staff because it was a unit that was just starting working on CHG treatments, and she came in with her being admitted and said, nope, I'm ready, here are my wipes, if you don't have them, I have them, so I want my child to have these every day. And that was a really great story that we were able to share throughout our units.
Never underestimate the power of data.
Great, thank you. I think we have another question.
Yep, and this one comes from Claudia Espinosa, and she's just curious, do you have any opinions about ethanol locks on the prevention of CLABSIs?
Sure, we do use them here. We use ethanol and we use other antibiotic locks as well for specific cases. It usually ends up being a lot of our GI, like our short gut patients, or some of our other really chronic, more special needs kind of kids that end up getting those ethanol locks, but we do use them at our hospital, Margie.
Likewise, it's a certain population of patients. The surgery services uses them a lot for the GI kids, the short gut kids. And I don't know, I'd say the results are probably not, statistically significantly positive, but that population has fewer infections, I think. That was an I think and not a we've researched it to see.
I think the bottom line is there is a role in perhaps a specially defined population. The data may not necessarily be overwhelming yet, but certainly it's one of the tools that can be used.
Great, thank you. I think we have another question.
Yeah, this is actually sort of a follow-up to the question we just asked, and this comes from Margaret Conway. She's asking, well, how do you identify that the line has an ethanol lock on it so they're not accidentally flushed?
So yeah, that's a great question because you have to be really careful about that, and we make sure that our lines are clearly identified as such when we do have those locks in place. We have a pretty I wouldn't say extensive policy, I would say very specific short policy to be really clear about what the expectations are around that, and then really being clear with everyone about some of the myths associated with the if you were to actually inject that and what would happen. So we really spend more time talking about that and really showing our staff where those resources are, and then making sure those lines are clearly identified at the bedside. So no, she's right. It does take some work to make sure all that's in place before you actually go out and implement.
I would just add to that the communication from shift to shift, from nurse to nurse, is just crucial. And that handoff is vital to, you can label it all you want, but here's another, I'll just reinforce it, that this line is locked for right now and that ends at this time, and et cetera. So.
Great, thank you. We did have questions that we didn't get to today, so we will follow up via email, and we'll even post a document to the website along with a copy of this recording so you can see how we answered the questions that were asked. So I wanted to walk everybody. We have gotten several questions on how to find the SPS prevention bundles and information about SPS. So I wanted to make sure that everybody's familiar with the SPS website, which is www.solutionsforpatientsafety.org. And what you're seeing right now is the homepage of our public website. And to get to the prevention bundles, you're going to go to the For Hospitals section and go to Hospital Resources and click on that, and you're going to see 3 orange boxes that come up. The SPS operational definitions for all of the hacks that you see to the right-hand side under the recommended bundles and the prevention bundles. All you have to do is click on it, and a PDF document will appear, and you can print that or save it to your desktop. The SPS recommended bundle elements or bundles are for adverse drug events, obstetrical adverse events, readmissions, and venous thromboembolism. So you can see the recommended bundles by clicking on the orange box as well. And then the SPS prevention bundles, which CLABSI that we talked about today is under that orange box. We also have CAUTIs or catheter-associated urinary tract infections, falls prevention, as well as pressure ulcers, surgical site infections, and ventilator-associated pneumonia. Another new feature to the SPS website is our Results tab. So you can click on our results, and you can see down at the bottom of the screen how much we have reduced each of the hacks or hospital-acquired conditions that we're working on within the SPS network. You can see each of our rate charts for each of the 9 hacks plus readmissions. All you have to do is click on the chart, and it'll come up in a larger fashion. And so you can see the SPS current rate and our reduction. So we're very excited to share our data transparently with other networks and other hospitals so people can learn. We hope to continue to learn from all of you. I'd like to thank you for joining us today and thank all of our leaders. And with that, I'd like to see if Steve has any closing comments he'd like to make.
Just a huge thank you to both our speakers again, and then all the participants, and that we really, in addition to trying to continuously reduce harm across all the SPS hospitals, we really, really want to share everything we're learning. Not that we're perfect in any way, shape, or form, but we believe that there's no reason to keep anything secret or private. So, and would love to hear from others as you come up with great ideas, because we really do, as Margie mentioned a while back, believe in all teach, all learn. Whether you're an SPS member hospital or not, we believe we're all in this together. So thanks to everybody.
Thank you. And again, on our public website is where you'll be able to find the recording of this webinar, I would say within the week. If you have any questions in the meantime, feel free to email us at ochsps@cchmc.org. You can get that email address off of our public website as well. And again, thank you and have a great rest of your day.